All right, so welcome. My name is Meets Ratley, and on behalf of the other organizers here, Dan Latt, Bart Loverts, and Bill Dew, welcome. We were just talking before we got on. I think this is our 4th year of the research interest group, so it's wonderful to see the little counter there on number of participants tick up. I've been asked to read some sort of housekeeping items here. So the first is that the session is being recorded. I think everybody saw the box. All participants are muted upon entry. Participant video is also turned off. If it isn't, please do so to limit bandwidth. Recording of the screen of any kind is strictly forbidden without prior approval in writing by the ORS and by the author and speaker. Please select speaker view for the optimum experience. Please take a minute to enter your name in the chat box. And if at any time you have a question, please enter it there, and we will circle up during the presentation. We've built in a couple breaks for discussion, so please do participate in that way. And then finally, the ORS asks that you strongly consider becoming a member. Use the Global Networking Lounge to learn more about it. So with that, I think I'm going to pass the mic over to Dan, and he's going to introduce our first speaker.
Well, thank you, Mead. It gives me great pleasure to introduce our keynote speaker. Dr. Scott Ellis is a friend, a colleague, and I would also like to say sort of a visionary in this area. He's going to be talking about how our understanding of 3D kinematics of the foot and ankle, which has been gained from weight-bearing CT, is changing both clinical practice and research. Next slide, please, Mead. Scott is an associate professor at the Hospital for Special Surgery, and he went to medical school at Johns Hopkins and then did both his residency and his foot and ankle fellowship at the Hospital for Special Surgery in New York. He's recently, he's the immediate past president of the Foot and Ankle Society's foundation, and he is also the program chair of our most recent meeting. Scott's research is strongly focused on studying the clinical outcomes of flat foot reconstruction, using weight-bearing CT to understand foot and ankle pathology, and in understanding patient-reported outcomes. He is a founding member of the 3D weight-bearing CT research group, and he is the head of research at the Hospital for Special Surgery, Department of Orthopaedic Surgery, and he oversees their patient registry. So Scott is in surgery this afternoon, so we've recorded his presentation, and we're going to start that in just a second. We have moved the discussion for this to the end, and if we roll over, I'd like everybody to, if you're interested, attend a discussion in the meeting room that the ORS has set up afterwards, and we'll post that link in the chat box. Okay, let's start the presentation, please, Mead.
Hi, this is Scott Ellis, and I'm going to do my best at attempting a recording here on Zoom that hopefully everybody will be able to see as I share this tomorrow. I'm really sorry about not being able to be here. I had a confusion on the actual date and time, and I'm in the operating room all day tomorrow. I'd actually put a lot of work and time into this talk, and really look forward to meeting and talking to a lot of you, a lot of who I already know through the Foot and Ankle Society and through all the work that you do and we do together. I want to thank Dan Latt and the group, especially for inviting me. We've known each other for a long time, and I really appreciate him and everybody here that's so passionate about research and forwarding our field. So he's asked me to talk really about some of the research that we do that we think is changing research and how we practice clinical care, and specifically about how weight-bearing CAT scan is going to shape the future of both research and clinical care. And Dan had originally asked me to touch also on some of our gait simulator work, because I know others of you out in the country are doing that as well. And it was a little bit less clinically relevant. I'm going to show a few slides on it, but mostly want to concentrate on how our work with weight-bearing CAT scan is shaping what we do. Please email me later or at any time. I'll put my email down here, lss@hss.edu, if you have any questions or comments, and I'd love to get back to you. A couple things real quick. I'm at home, have 2 dogs, a daughter, and a wife doing yoga in the background, so there might be some interruptions, and I just hope this goes through without a hitch, but I'm going to keep on moving. Okay, so the learning objectives today are to understand what the current published research is in weight-bearing CAT scan when assessing foot and ankle pathology. I also want to be able to apply the weight-bearing technology that we're doing to clinical cases and future research, and specifically touching on cases involving hallux valgus, those of syndesmosis, the adult acquired flat foot, or as we're calling it now, the progressing collapsing flat foot deformity, and a little bit on ankle arthritis. I'd had two polls that Matt had helped me potentially set up, mostly to get a sense for what the audience has and is using in terms of weight-bearing CAT scan. And although these will be irrelevant, I wanted to know what everybody, or how many people I should say in the audience, are using weight-bearing CAT scan in their clinical practice. And again, how many are using it in research. And I have a feeling that this number has increased over the last several years, and I'm pretty confident it's going to increase even more in the years to come. I want to thank Cesar Doneto, my close colleague who's now at the University of Iowa. He and I have done a lot of work together, and a lot of what you see and learn today is thanks to some collaboration with him. And I actually asked him if I could use some of his slides, although I wanted to tailor this talk specifically to what I do. Okay, so what will the role of foot and ankle, weight-bearing CAT scan be in the future of foot and ankle surgery? And I think it's, like I said, going to change our practice dramatically. We started essentially with weight-bearing CAT scan at our institution with an apparatus that looked like this. It was the Philips Eleva. This is probably about 15 years ago. And this is, in fact, one of our current fellows who was at the time a research assistant with us, standing up on this platform, which is probably dangerous to everybody that we put on there. And I'm surprised the hospital let us do this. But we started capturing early weight-bearing CAT scan data. And of course, we've come a long way now. This is a picture of the current scanner that I use, and this elevator here is just down just 5 floors down from where I practice. And patients can literally go from my office down the elevator and through this door, and there they are, the weight-bearing CAT scan. So a lot of times, barring insurance issues, which I'm really not going to talk too much about today, but they can get it quite quickly. So like I pointed out before, where is it changing my practice? And I already talked to you about these four. I'm not going to list it again. Or state it again, rather. But these are where it's really starting to make a difference for me, and I think also is the way of the future, and there will be other applications as well. It's important to know where we stand with data, both to drive clinical decision-making and also to understand where the research can take us. A lot of what we're doing is just validating a lot of the old two-dimensional parameters that we would look at on just plain X-ray, now moving them into a three-dimensional environment, if you will. And we have some good data on a lot of the pathologies that I've already mentioned. Although really we're still in the infancy, and we're really brainstorming with a lot of future ideas. This is a PubMed research that Cesar and I had done recently in the setting of hallux valgus using weight-bearing CAT scan, and there's already 30 or more studies looking at its role, and it's really becoming clinically helpful for me. And it is essentially the third dimension, not only because it's three-dimensional in itself, but it's taking us to a new level of understanding. Just to highlight a couple studies that have been done so far using a weight-bearing CAT scan in the setting of bunion. There's been a lot of research understanding how in the setting of a bunion or hallux valgus, the first metatarsal rotates, not just deviates over into metatarsus primus varus, but how it actually rotates. There's also a lot of work looking at sesamoid position, because as a bunion occurs, the sesamoids start rotating. So you can see normals are on the top here, and are the normals on the top. And as the bunion gets worse, there's a rotation and a pronation of the metatarsal, so its axis starts changing, but also the sesamoids start rotating out from underneath. And we believe the more and more we see this, the more important it is to restore that at the time you fix a bunion. There's also a very much better understanding of sesamoid pathology. A lot of the patients with hallux valgus have sesamoid arthritis, and we can start classifying that, categorizing it, and using that to predict who's going to do well after surgery. But this is a study published out of the UK looking at sesamoid arthritis and pathology, which you can really appreciate on weight-bearing CAT scans, particularly that coronal view that you're seeing here. There's been a lot of discussion about this so-called DMMA, this longstanding belief that maybe in some patients there's a deviation of the articular surface of the metatarsal head. What we're understanding is that distal angle may actually be just simply a reflection of pronation of the metatarsal head. And I'm going to show you a couple of examples shortly, but some of our colleagues from Chile had designed a study where they correlated the amount of pronation to the appearance of that head, and they use it in one of their techniques to do a proximal rotational edge osteotomy of the metatarsals. I personally believe that the rotation is mostly what factors into how you see that metatarsal head on an AP X-ray. So here's a typical case of a patient with a hallux valgus, although I'm not showing a weight-bearing X-ray of 35, an IM angle of 22, maybe has a DMA, and maybe has pronation. Which one is it? It's hard to say. Here's what a weight-bearing CAT scan looks like in them, with the sesamoids really rotated out of position, and essentially that metatarsal pronated. Here's a sense of the articular surface, which taken on this view actually looks perpendicular to the metatarsal shaft, although here it doesn't. One is a weight-bearing CAT scan, the other is the metatarsal. But if you really look at it, and this video shows you, if you rotate this metatarsal, and that's what this pin is doing, depending on how you look down the axis of that metatarsal, those sesamoids are more or less reduced. So really, it may come down to just a concept of straightening the metatarsal and reducing the sesamoids by rotating it. So that probably changes your surgical plan. At least it has in my experience. And so what I'm doing very commonly now is doing a Lapidus procedure. And I'm going to show you an example here where I use the Lapidus to not only correct the metatarsal position in AP and lateral plane, but also to rotate it. Now, this is a patient who had a previous surgery. You can see where it was more of just a distal minor osteotomy with a shaving of the medial eminence. You can see on the bottom right how the sesamoids have rotated out of position. You can see on the top one of the sesamoids as well, and I can look at the TMT joint, which looks actually normal in this case. But I used that rotated. I did shave some bone distally, but rotated in position, fused the TMT joint, and now look at my sesamoids. They aren't quite perfect, but pretty good, and this patient's done quite well. The weight-bearing CAT scan also allows me to really understand if the joint, the TMT joint's healed. And I usually get this about 4 to 5 months after surgery. I'm getting out everybody pre-op. So in terms of how the weight-bearing CAT scan is going to guide future research, it's going to give us a better understanding, as I alluded to before, about the concept and magnitude of metatarsal pronation and sesamoid position, both before and after surgery. What we need to do next, and with your help, is correlate these weight-bearing CAT scan parameters with clinical outcomes, because it has not been proven that reducing the sesamoids or these parameters actually helps the clinical outcomes. I suspect it will. And then at some point, we really need to take it to the next level where we don't have to sit there manually calculating the axes and these different degrees. We can have software do it for us in an automated fashion. Okay, so next I'm going to talk to you, and I'm just checking my time here, on the next subject, which is going to be syndesmotic injury or stability. This is probably where I use it the least. But there already are 23 results in the literature on the use of weight-bearing CAT scan in syndesmotic injury. Some of those of you on the call, or excuse me, on the meeting, have been doing this work. And really it comes down to, and as always, understanding the difference between having a syndesmotic injury and syndesmotic instability. You can have injury without instability, but what drives our clinical decision-making in surgery is when the injury leads to instability. And here's an example of a patient on an MRI with what looks like AITFL tear, and intraoperatively this arthroscopy shows that syndesmosis, the junction between the tibia and the fibula, looks unstable. But how can we predict that? Well, our colleagues out of Utah have taken a cadaveric approach, loaded a specimen with weight-bearing in a weight-bearing CAT scan, and showed that if you simply just load that, there's no change with parameters that are used to assess the syndesmosis. I'm not going to go into great detail in terms of what those are. However, when you take the same model and apply external rotation, you do see widening of the syndesmosis, which can be predictive of somebody who has instability. So an early sign that, that this weight-bearing technology can help guide when we need to fix the syndesmosis. There's been some great work out of Harvard looking at these volumes of the syndesmosis, both in abnormal and normal. In this case, the abnormal is on the left with the wider volume suggestive of syndesmosis widening or instability. And they showed a significant difference, a significant increase, I should say, in the volume in patients that had an injured syndesmosis compared to control. And one of the beauties of these scanners is you can actually have the patient's both legs in the scanner and compare the injured side to the non-injured side and look for symmetry. The same group then later took this volumetric measurements to the next level and again found in patients with an injury increased volume. And there goes the dogs, as I promised that they would, which I can't control them, so I'm going to keep on trucking. But basically, a lot of promise of using weight-bearing CAT scan to compare both sides and diagnose who needs to be fixed. This is a case that Caesar put together. It's somewhat an obvious case because in the injured patient, you see a little fleck of bone on the back and the fibula is anteriorly translated. However, if you measure the volume there, you can see on the injured side, it's greater on the right side compared to the left, which, as we learned from the research, is suggestive of an injury. And again, you can take in three-dimensional fashion, as we're showing in this video, a real-time look at those differences, and it would indicate the patient needs surgery. Here's what Caesar did. It was that picture I showed you in the beginning, scoped the ankle, showed that there was instability, and ultimately fixed this patient with a suture button technique. So how is this going to guide us in the future? Well, weight-bearing CAT scan is going to give us a better understanding when diastasis and instability is present and clinically relevant and guide when we go to the operating room. I think it will also help us understand better when we have a reduction. Again, the findings here and the ability to reduce the syndesmosis effectively need to be correlated with clinical outcomes. Okay, probably most near and dear to my heart is and how we started with all this at our institution was looking at the flat foot and trying to understand how this can be helpful, how weight-bearing CAT scan can be helpful in treating these patients and how it can drive our research. And there's, if you look, almost 40 studies, and probably now even more than that, looking at the progressive collapsing flat foot deformity, as we're now hoping to call it as part of this consensus group statement we published in October. But there's a lot out there, and really this truthfully is going to take us to the next dimension. Here's the consensus group I just mentioned, a group of 9 leaders that we organized and met in November of 2019 before COVID, thank goodness, when it was all possible, although I certainly could do it now virtually, and I'm confident we're going to be coming back to this and not too far in the distant future. But basically, published these, like I said, in the October version. It's a whole series of consensus statements on what we believe are not necessarily statements borne out from direct literature, but a collective, large-scale experience on how we think certain components of the deformity should be measured and managed. But one of the consensus group statements was on the use of weight-bearing CAT scan. And long story short, we felt that everybody who had a weight-bearing CAT scan should use this to assess the flat foot. We could not mandate or say that everybody had to use it because it's not universally available, but we think it's going to be an increasingly powerful tool. A lot of this work started back at the University of Washington with Bruce St. Georgian and his group. Long story short, they started noticing this concept of peritalar subluxation with the calcaneus and all the other bones coming out from underneath the talus, and they did this on simulated weight-bearing CAT scan with this plexiglass apparatus. They would advance load up against the foot. They started delving into understanding when flat foot patients had lateral pain and understanding that in some cases this was due to either impingement of the calcaneus and the talus at the sinus tarsi or the calcaneus up against the fibula. We took this with our new weight-bearing CAT scan to another level and started comparing flat foot patients versus controls and looked at a parameter, which was the orientation, as you can see on the left screen here, of the subtalar posterior facet compared to the superior surface of the talus. That is the superior versus inferior surface. And what we found is in flat foot, that inferior surface tended to be more and more valgus throughout a spectrum from anterior to posterior of that subtalar joint. And the magic number in the middle of that joint of what really differentiated flat foot versus control was 17 degrees of valgus. So there's something about the orientation of that joint that leads to the development of this deformity. And where I use it in practice is that if I have a patient with lateral pain, x-rays such as those two above and all in the same patient don't necessarily show me where the lateral pain is coming from. But if you dive deeper with the weight-bearing CAT scan, same patient, you can see that the calcaneus is bumping up against the fibula, so that's subfibular impingement. And even in the same patient, they have an element of impingement of the calcaneus up against the talus, so or sinus tarsi impingement, or talocalcaneal impingement. Again, same patient, borne out much better on the weight-bearing CAT scan. Caesar and I have been looking at a new parameter, which is probably, we think, more sensitive, but looking at a parameter that assesses subtalar subluxation, and that is the middle facet. So here's a group of controls on the left side, and we published this in JBJS, and on the right side are flat foot. And what you can really see is the calcaneus starts slipping out from underneath the talus, and this is at the middle facet, not the posterior facet, but the middle. And you can see how dramatic this can be in a patient such as that on the right, where it's almost 100% sublux. The magic number in this case that we found that really differentiated controls from flat foot was about 18%. So it wasn't even nearly as much as that example that I just showed you. And we think this may be a marker of not only the severity, but maybe in patients who you might consider subtalar fusion as opposed to a flat foot reconstruction, which is for another time. A really interesting automated parameter that we've already started using and using in flat foot is this so-called foot and ankle offset, where the software automatically points out 3 points, first metatarsal, base of fifth, and the heel, which is not a new concept to all of us, but the computer does it for us, and then averages that out to give us what's called the foot and ankle offset. And that can be affected by many components of the flat foot, including the longitudinal arch, the hind foot drifting into valgus, forefoot abduction, etc. So we're understanding how different components of the flat foot surgery will correct the foot and ankle offset. More recent research, we've looked at weight-bearing CAT scan and compared it to MRI findings, and just started to delve into this, but found that in the same set of flat foot patients, there are pretty distinct comparisons between what ligaments are failing and where you see deformity. So for example, this is a patient with subfibular here and sinus tarsal impingement. Another person with that increased valgus posterior facet and some medial facet subluxation, compared that to findings of the spring ligament that we had our expert radiologist read, as well as the posterior tibial tendon, and then did a correlation and basically found that the generation of the posterior tibial tendon was correlated with sinus tarsal impingement. Spring ligament degeneration was associated with subtalar joint subluxation, and I'm going through these quickly, but talocalcaneal impingement often, or talocalcaneal ligament rather, was often, our failure was often associated with subfibular impingement. So early signs that you might be able to predict what ligaments have failed based on what deformity you're seeing in weight-bearing CAT scan. Some of the more exciting research, and I know some of the group here has done this, but where you do what's called distance mapping. And that is on CAT scan, you can look at the distance between various bones and get an understanding of how they sit with each other, how they load, and where the bones might be subluxating or causing pressure. And we looked at three-dimensional both coverage maps and distance maps. And I'm not going to go into great detail, but to understand how patients with flat foot have variations. And long story short, you can see on the right, in a control, you have a nice blue area where the calcaneus sits right underneath the talus, whereas in a flat foot, the area where the two bones touch starts becoming more narrow and more laterally displaced, and you start getting the equivalent of really increased pressures, which can cause pain and other problems. Here's another example of a coverage map. And basically what we've found is the overall coverage in the cartilage or articular areas goes down, impingement in areas where it's becoming more narrow that shouldn't be joining goes up in patients with flat foot compared to control. And the medial facet, again, was a very important place where we found significant uncoverage, and it's probably more sensitive in the posterior facet. And the increase in sinus tarsi coverage was found to be increased in 6 patients. There goes the dog again. I'm going to go quickly through these because I want to show everybody the next steps. What we are starting to do is modeling with the help of this company, some of those changes as the foot goes from a predicted normal foot to a flat foot. And again, distance maps and coverage maps that you might be able to develop with the automated software. Another important use of these distance and coverage maps will be understanding what things look like pre-op versus post-op. And the idea of the surgery is to restore normality in both distance maps and coverage maps. There's pre-op to post-op. Again, pre-op to post-op. Okay, I wanted to touch briefly on our gait simulator research. Again, checking my time here, I'm running a little bit low on time. This is some of the work that our group has been presenting, and Jensen Henry is going to be presenting here at the RS. Basically, simulating a flat foot model and trying to understand what different components of a flat foot reconstruction will do to the kinematics of the cadaveric flat foot, but basically took a series of mid tibia cadaveric specimens, mounted them as a lot of the work we learned from our colleagues in Seattle, advanced their weight up against his foot, also took plantar pressures, and we designed a flat foot model based on some of the work, a lot of the work, I should say, that Jonathan Deland had done. And basically have validated this model and also understood some of the flat foot pressures and how we might relate that to what we've seen clinically. And these are some of the findings that we've come up with in the flat foot patients. You can see the curves of normal versus flat foot. And long story short, and I think many on this meeting are going to be more experts than I am, but there are significant differences we start finding between normal and flat foot in this model, where we've released things like the posterior tibial tendon, or decreased, I should say, released the spring ligament, interosseous ligament, etc. And again, there's a range here, and you can see kind of the repeated measures differences between normal and flat foot. Again, same patterns or similar patterns, I should say, should be found or can be found in the subtalar joint and the talonavicular joint. So we think going forward, it's going to be a very powerful tool. Okay, so going back to weight-bearing CAT scan, it really ties into my treatment when I decide what to do with the flat foot deformity. Again, here's a very significantly valgus-oriented hind foot. There's some subfibular impingement and sinus tarsi impingement. And when I start seeing any of those in a very severe deviated FAO, I'm starting to think that instead of doing a flat foot reconstruction where I slide the heel and transfer tendons, I may well fuse a subtalar joint, because my worry is either they'll have continued pain from impingement, or even if I move and restore some normality to the anatomy, it might just continue to collapse over time. So ways where it's really helping us. And then another way is on a lateral or the sagittal of the weight-bearing CAT scan. I can see where the plantar gapping is occurring at different places along the medial column. If it's at the TMT joint, it might drive my decision-making to fuse that joint. If it's at the navicular cuneiform, I might do a cotton osteotomy, which is a opening wedge of the medial cuneiform. If it's at the spring ligament, you might start worrying about the spring ligament, think about repairing it or reconstructing it. And finally, as I said before, and this is more for a coronal view, but if you see a medial facet subluxation, you might fuse that joint. Here's a prime example of a patient of mine who had significant gapping of the tarsometatarsal joint with arthritis at the top, sinus tarsi impingement. This on the left drove me to fuse a TMT, that on the right to do a subtalar fusion. You can see how far the heel's out on the plain x-ray. And I ended up also fused the talonavicular joint just because in part her deformity was so severe. And she's doing quite well. I worry that that would have failed otherwise. So I think in the future, we're going to use this to guide our understanding of flat foot, to understand the complex anatomy of the deformity. It's going to guide the various types and amounts of the osteotomies that we do, and that's largely based now on just our plain x-ray understanding. And automated parameters for sure will be the future. And like the other two conditions I've talked about, we want to correlate ultimately clinical outcomes with restoration of the anatomy that we're finding on weight-bearing CAT scan. Finally, and briefly, I'll talk to you about how we're using this in ankle arthritis and deformity. A lot less work has been done on this, although we did find 34 studies. Ankle arthritis also involves the foot sometimes, and deformity. Weight-bearing CAT scans have been a very useful tool for me to understand how the foot plays in with the ankle, and also helps me guide my total ankle replacements. The current system I'm using takes a scan of both the knee and the leg and gives me alignment, both mechanical and the anatomical alignment. Excuse me. And I can go in and determine the axes of the bones and different planes of deformity and different angles and axes that I want to put that total ankle in, including the rotation, varus valgus, the slope level that I cut on the side. I come up with a plan that I can then put into action. And here's how it looks in the operating room on the left after I put these jigs together that the pre-op CAT scan allows me to afford, and then helps me determine axes and ultimately, put in a well-balanced implant. And here's a nice example on the left. So I'm not going to go into in huge detail, but it is an increasingly important area where weight-bearing CAT scan is guiding our treatment. So in the future, it's going to guide our ability to put implants in correctly, understand the entire leg alignment. It will help me, as I said before, plan both what to do with the ankle and in some cases the foot simultaneously. And it's becoming a huge tool. So In closing and in summary, the body of weight-bearing cat scan is growing fast. It's really driving a lot that we're doing in terms of decision-making. It's driving research. It's going to be the standard of care, I believe, in the future. I think one obstacle that people have is potentially cost, but I'll tell you, if you start using it and you can use it as standard of care, the unit starts paying for itself very quickly. I strongly recommend it in conditions that I mentioned before and went through: hallux valgus, syndesmotic instability, the flat foot and ankle arthritis, particularly with total ankle planning. I'd like to thank my colleagues in the International Weight Bearing Society who've done a lot of the hard work and thinking and really promoting the use of this tool, but more importantly, an overall understanding of how to make our foot and ankle patients better. And again, sorry I can't be there in person. Feel free to reach out to me, ellis@hss.edu. I'd be happy to ask questions. I wish you luck in the rest of this meeting and can't wait to see you when we get to the other side of COVID, which won't be too long. Thank you.
Great. Thanks, everybody. So the next presentation we're going to go is, I'm going to hand it over to Bill, and he's going to introduce the speakers.
Thanks, Mead. If you could start sharing your screen. Thank you.
Absolutely. Certainly wants to start there.
Great. So our next speakers are Amy Lenz and Karen Kruger. Their topic is techniques for embedding local coordinate systems in foot and ankle bones. Amy is a research faculty in orthopedics at the University of Utah. Her focus is foot and ankle orthopedic biomechanics. Karen is an assistant research professor at Marquette University, where she's an engineer in the Motion Analysis Center at Shriners Hospital in Chicago. And her research interests are also biomechanics of the, her interests are biomechanics of the pediatric foot deformities.
Amy, I think you are going to present from your computer. Is that the plan?
Correct. Can everyone see that well? Excellent. So I wanted to start out by saying how this collaboration has come about and how and why Karen and I are so passionate about creating a standard and helping the community to be consistent. Because we currently have a funded multi-site grant. And when we started these discussions, we realized the discontinuity of techniques to arrive at meaningful in vivo kinematics of both the tibiotalar and subtalar joints. And this really led to a great collaboration and our passion for this topic, and why we've now written a systematic literature review to report this. So starting out about this topic, it really wasn't a big deal until the advent of biplane fluoroscopy created the ability to measure and evaluate in vivo tibiotalar separate from subtalar motion. And it was back in 2002 that the International Society of Biomechanics proposed standards for reporting ankle kinematics. But at that time, it was recommended that the ankle joint was comprised of both the tibiotalar and the subtalar joints due to the measurement limitations, because it was really addressed for a skin-based motion capture approach. And they said that this should be addressed at a later time. Well, now almost 20 years later, we still don't have that standard, and there's quite a bunch of variability in the existing literature. So we have set out to create this study, and the objective was to perform a systematic review that was to evaluate the existing literature that either defined, one, the coordinate systems of the tibia, talus, and calcaneus, or assigned kinematic definitions for the tibiotalar and subtalar joints. So our systematic review consisted of help from a librarian in order to do a multi-database search, in which our inclusion criteria was any use of 3D imaging. It could be CT, MRI, or even weight-bearing CT. The mention of the ankle joint complex, and defined coordinate systems either for those bones of interest or calculating 3D kinematics as well. And what we found was that we had a very wide variety of things, and there wasn't much consistency. So part of this, we also developed a methodological evaluation to assess these different studies on a scale. And that was really helpful. We drew inspiration from 2 different published evaluation standards, the QUACs, and then also a Trindler et al. Study that looks more at the in vivo motion aspect of rating studies, methodological assessments. And so what our systematic review revealed were 52 articles that met our inclusion criteria, and their resulting rank of methodological quality ranged from 61 to 97% out of a total of 100% scores. And of our included articles for the coordinate systems, we saw they fell into 3 main groups. First, the anatomical coordinate system based approach, which could be landmarks and/or geometric shape fits to assign axes definitions. Second is the mathematical approach of orthogonal principal axes. And then lastly, another mathematical approach of using iterative closest point registration to assign coordinate systems. And so of the more interesting results, I'd say the more widely used as well, were the landmark geometric and/or a combination of landmark and geometric based. And interestingly, the primary and secondary axes were pretty consistently approached in similar methods. So for the tibia, the superior, inferior, and then medial lateral axes were most commonly defined by either landmark or geometric fits. For the talus, it was an anterior-posterior approach for an axis with medial lateral axes as second. And then for the calcaneus, it was kind of a mix, but most consistently, it was a superior-inferior axis and then anterior-posterior. And here's all the articles. And to put a visual to that, we have some of the most common approaches shown here. And what's really concerning is that only 3 of our 52 studies reported reliability metrics on how well these were reproducible for both intra and inter-rater reliability. And as you can imagine, for either of these landmark or geometric approaches, there can be quite a bit of selector user input bias to where and how these axes are defined. So now Karen will take it away with the kinematics.
All right, thanks, Amy. So we wanted to include kinematics in this presentation as well, because while we originally got into this whole systematic review with the interest of embedding local coordinate systems, we also found as we started doing our initial review is that there's quite a bit of variability in how the kinematic calculations are defined study to study, and that in itself can also induce quite a bit of variability. So in looking at the different methods that these articles use to calculate kinematics, they fell into 3 different bins. The joint coordinate system as defined by Groot and Sante, which was consistent with what the ISD standards prescribes for the knee, hip, and ankle. And then also Card and Euler sequences had the most actually. And then we also had 9 articles that calculated kinematics from helical angles. Oops, sorry, next slide, Amy. So to talk about the articles that use the joint coordinate system, so this requires defining both the primary axes on one of the bones you're analyzing and then a secondary axis on the second bone. So most articles defined the primary axis as a medial lateral axis and the secondary axis as the AP axis, which is consistent with the ISB standards. However, there were a few other alternative definitions that are shown at the bottom of this slide. Next slide. So the most common way that these were calculated was using Cardin or Euler sequences. The most common derotation sequence that was used was a sagittal coronal transverse, which is consistent with how most gait models calculate hip, knee, or ankle kinematics. However, we found that there were a handful of other papers that used either a sagittal transverse coronal rotation sequence or in 2 cases, a coronal transverse sagittal. And then there were also a handful of articles that didn't specify their rotation order. Next slide. So to summarize all this up, within the coordinate system definitions, we found that there was quite a bit of variability study to study, and that all of the methods used both have their own pluses and minuses. When you're looking at the anatomic based coordinate systems using either predefined points or surfaces to primitives. They're subject to inter-rater reliability, either person to person or repeated trials within the same person. And unfortunately, that is not well documented in the current literature. So we don't really have a means to say which ones are the most reproducible right now. Using principal axes actually removes that limitation, because whenever you compute principal axes to a solid model, you're always going to get the same result. However, this is just taking into account an axis based on the whole shape of the bone, and it's not necessarily getting a true representation of what that articular surface looks like within the bone that we're really interested in. With the variability in the kinematic definitions, one thing that Amy and I, as biomechanists, really had to dig into is that traditionally in biomechanics literature, the joint coordinate system and Euler-Cartan sequences are treated as these two different methodologies. However, we actually found two separate papers that did mathematical proofs that showed that these two methods are, while you start with different definitions, they're mechanically or mathematically equivalent. So I think that's one thing we really want to make a little bit more widely known as we're considering these different definitions. So when looking at these definitions, the most common definitions define sagittal motion as the primary direction of motion. So based on what we know about these kinematics, this is probably appropriate for the tibio-talar joint. However, when you're looking at the subtalar joint motion, some of the early biplane fluoroscopy work that's come out of Utah and some of the other groups has shown that that sagittal motion's not the primary motion. So a different rotation sequence might be most appropriate. Helical axes are a way to compute kinematics without having to worry about it. However, they become unstable when very small rotations are being used, especially like at the subtalar joint, which might be a limitation, especially with the current accuracy of model-based biplane fluoroscopy. So to summarize things, our main goal of this was just to provide summarized knowledge that could be used as a basis for us as a foot and ankle biomechanics community to create accepted standards for reporting these tibio-talar and subtalar kinematics. Because I know there was a big conversation at this rig last year that actually spurred me and Amy to decide we really need to get organized with this. And I know her and I have both had conversations with multiple people about this. We don't really claim to know what's best, but I think a lot of us are just in agreement that we need some form of standard so we can all start using the same models and using it to enhance our understanding of these joints. So thanks to Bill and the rest of the organizing committee for letting us discuss this work. And I think we've got a couple poll questions. Matt's gonna queue up here.
Well, Matt, I saw them quickly, but they just as quickly disappeared. There we go.
Those are for Scott's.
These were Scott's. I can remove them.
It's okay. We could click through them too.
Yeah.
And then one other thing that we threw some inspiration up on this slide for as well is acknowledging that the patient populations we're interested in and that Karen and I evaluate as well may not have typical anatomy and morphology, and how that varies our standard, I think, is really important as well to understand and create coordinate systems and kinematic sequences that will be most meaningful to all types of tibio-talar and subtalar morphology.
So while we're waiting for the poll to come up, I had one quick question for Karen and for Amy. What's next? Sounds like there's not consensus in the literature, and what does the community need to do?
So that's part of what we want to spur as an open discussion, why we didn't go in depth into all the literature, but give a brief overview. And our poll here is to ask who would be using a standard if we created it. Do you have interest in that? We'd really like to make this be a community effort so that we can facilitate more multi-site studies, especially as it is right now. Doing biplane fluoroscopy tracking is quite time intensive. And so if we were able to compare data from multiple data sites more easily with a standard to facilitate that, I think that's where we see the value in having this community discussion.
Great, thanks, Amy.
And then I think using the model that the ISB originally used 20 or so years ago, where they basically invited a panel of experts in that field to start to hash out some of these differences and which ones are actually useful and which ones are just too variable to be useful, would be a really good starting point.
It's a great point, Karen. So we're running up against the time limits. There were a few questions that were asked to Amy and Karen in the chat window. So I'd ask you guys to look at those. And it looks like there's an overwhelming interest in this, at least in the members who are on this call.
Excellent. That's really encouraging. And we invite all of you to reach out to us and to start that type of a panel discussion. We have some ongoing research where we're doing our own efforts to compare reliability and anatomic-based variability. And so getting more pathologic data sets in together to strengthen that analysis could be a great place to start as well, and to have group discussions.
Great, thank you. Okay, with that, we're going to turn the floor over to Bart.
Unmute. So, hi everyone. We have 4 poster teaser presenters, and I think this is a great opportunity to show your research to the research community and also create some discussions afterwards. So I would like to give the word to our first presenter. That's Rohan Bhimani. He's part of the Foot and Ankle Research and Innovation Lab at Massachusetts General Hospital in Boston. And please, Rohan, go ahead, presenting your research.
Hi, everyone. Thank you so much, ORS Foot and Ankle RIG Group, for the opportunity to present our study entitled Weight-Bearing CT Can Effectively Diagnose Lisfranc Instability. Subtle Lisfranc instability can be challenging to diagnose even on weight-bearing radiographs. Recent literature has shown that about 1/3 of these injuries are even missed on weight-bearing radiographs. In such situation, if Lisfranc instabilities are missed or misdiagnosed, it can result in significant patient morbidity. When there's high clinical suspicion of such instabilities, clinicians often turn towards advanced imaging modalities like MRI and conventional CT scan. MRI usually identifies injury, but does not comment on instability. And conventional CT scan allows us to evaluate alignment, but without physiological load. On the other hand, bilateral weight-bearing CT scan allows us to evaluate alignment under physiological load, and also provides us to compare with the contralateral healthy side, which acts as an internal control. So the aims of our study was to evaluate the ability of weight-bearing CT scan to diagnose Lisfranc instability among patients who were surgically confirmed to have that instability, using contralateral uninjured healthy side as internal control. We also aim to compare the sensitivities of one-dimensional linear measurements, two-dimensional area, and three-dimensional volumetric measurements of the Lisfranc joint. Our hypothesis was that weight-bearing CT measurements are increased on the injured side compared to the healthy side, and 3D volume measurements are the most sensitive parameter to detect such instability. Next slide, please. So in our study, we included 2 groups. One was the study group, which had 14 patients who had unilateral Lisfranc instability, which was confirmed intraoperatively and had undergone preoperative weight-bearing CT scan. In the control group, we included patients who did not have any injury to their feet and had undergone weight-bearing CT for other reasons, like, for example, ankle injuries. So as you can see in figure 1, we measured the linear distances and 2-dimensional areas. This is the scan of a patient who has left-sided Lisfranc instability. And as you can see, all linear as well as 2-dimensional measurements are increased on the left side compared to the right side. We also measured 3D volumetric measurements in coronal and axial plane. And as you can see on in figure 2, where patient has right-sided Lisfranc instability, the coronal Lisfranc volume has increased on the injured side compared to the uninjured healthy side. Next slide, please. So moving on to our results, what we found that all one-dimensional, two-dimensional, and three-dimensional measurements were increased on the injured side compared to the uninjured healthy side. Notably, the Lisfranc volumetric measurement showed largest side-to-side difference compared to other 1D and 2D measurements. In our control group, there was no difference between the left and the right foot for any of these parameters. Next slide, please. So what are the take-home messages from our study? That all 1D, 2D, and 3D measurements can be used to identify Lisfranc instability. The Lisfranc volumetric measurement in both coronal and axial plane had the largest absolute difference compared to 2D and 1D measurements. And when such instability becomes increasingly subtle, these absolute values are also going to decrease. And the one that has largest side-to-side difference becomes most applicable in cases of questionable injury. And in our study, we found that the 3D coronal volumetric measurement had the largest side-to-side difference and makes it the most sensitive parameters among all other measurements to detect Lisfranc instability. Thank you, and I'm happy to answer any questions.
Thank you, Rowan. We go to our next speaker, which is Jae-young Kim from the hospital special surgery in New York. Please go ahead.
Thank you. Hi, my name is Jae-young Kim, and I'm honored to present our project at this meeting. Our title is Influence of Primary Arthrodesis of Tarsometatarsal Joint on Gait Kinematics in Cadaveric Simulation. Next, please. In the surgical treatment of Lisfranc injuries, primary arthrodesis is becoming a popular option over open reduction and internal fixation due to its low reoperation rate and equivalent clinical outcomes. However, despite the assumption that long-term sequelae of TMT arthrodesis might not be significant, there is limited data on the effect of TMT arthrodesis on the foot and ankle kinematics. Therefore, the purpose of this study was to determine the influence of TMT joint arthrodesis on foot and ankle kinematics. We hypothesized that primary arthrodesis would not change the kinematics of ankle and adjacent joints. Next, please. 10 mid-tibia cadaveric specimens were prepared in a previously defined method, and we loaded the specimen onto a validated 6 degree of freedom robotic gait simulator, which uses in vivo muscle forces and tibial kinematics as inputs to replicate ground reaction forces. After the intact simulation, sequential arthrodesis of the first and second and third TMT joints was performed with dorsal Lisfranc plates. The specimen was then loaded onto the simulator, and 3 simulations were conducted with consistent inputs. Foot and ankle kinematics were compared between the intact and arthrodesis conditions. Next, please. This is result. In the ankle and subtalar joints, there were no significant differences between the 2 conditions. Next, please. In the talonavicular and first MTP joints, there was a strong correlation between the 2 conditions in the primary planes of motion. However, only a moderate correlation was found in the sagittal plane of the talonavicular joint and the transverse plane of the first MTP joint. Next, please. The range of motion data showed a small range of motion across all TMT joints in the intact condition, and there was a significant decrease of motion in most TMT joints after arthrodesis. The data in this study support our hypothesis that TMT joint arthrodesis results in minimal changes in foot and ankle kinematics. The smaller range of motion observed in the TMT joint corroborates with previously reported values, and therefore TMT range of motion may not be clinically relevant towards the foot and ankle kinematics. In conclusion, primary arthrodesis has a minimal effect on the kinematics of adjacent joints during simulated level walking, and this may support the use of primary arthrodesis in the surgical treatment of Lisfranc injury. Thank you.
Thank you so much for presenting that interesting research. Our next speaker is Irfan O from the University of Rochester.
Hello. So my topic is on about simulating a thoracalar implant. So nowadays there's more increase in interest in using thoracalar implants for management of various talopathology. And we couldn't really find any literature on its biomechanics. So I was talking with Hani Awad, and I asked him, how can we study this biomechanics? What's the biomechanical effect of thoracalar implant? So initially we were going to study by putting in a custom 3D implant of the talus, but he said, why not just take out the normal talus and study how it goes when you put it back in? So I thought that was a good idea. So we decided to study that. And our hypothesis was that the interosseous ligament between the talus and calcaneus is very strong, and that may provide the strongest stability when especially when you're plantar flexing. And without that, we hypothesized that the talus may become unstable. So next slide. So we created this model where we're simulating a mid-stance and seated heel raise model. So we utilize a cadaver specimen, and we sequentially sectioned ligaments. So we started with lateral ligaments. Then we, of course, we first studied our initial under mid-stance and seated heel raise models. Then we did a sequential release of lateral ligaments. Then we conducted a biomechanical analysis of a mid-stance and seated heel raise. Then after deep deltoid, then after talonavicular joint capsule, then after sectioning the talocalcaneal interosseous ligament, then after soft tissue repair, because we felt that some of the muscle and soft tissue skin were providing some stability. And we cyclically loaded and measured their kinematics. The next slide. So I'm showing you just a talonavicular static angle and displacement angle. There's so many other angles that we measured, including subtalar, tibiatalar, and talonavicular, axial and coronal and sagittal view. But really, I think to prove our point, that two graph really kind of shows what we found. And if you look at that, when you do a lateral release, you don't see much of a difference compared to initial. There's no statistical significance between lateral release and the initial condition. But when you go into talonavicular release, you start to see some difference between the initial condition. Where you see the most difference is when you release the interosseous ligament between the talus and calcaneus. So we believe that that strong ligament between the talus and calcaneus is really what provides the stability to the talus. So especially when the patient is in seated heel raise position or plantar flexion position, the talus kind of lifts up. And then that's what you can see in the sagittal static angle, as well as if you look at the displacement, it significantly increases. And you can see how much of the soft tissue and skin provides stability. So when the soft tissue skin is repaired, and it kind of provides a little bit more stability, but not enough to improve that instability compared to initial condition. So through this study, what we found out is that when you have a total talar implant, we believe that there's a potential for having an unstable implant at the plantar flexion position. Certainly this is an imperfect model, but that kind of gives us an idea of what we should investigate further down the road.
Thank you for presenting that. Our last author is Jing Sheng from the Rehabilitation Research and Development Center for Limb Loss and Mobility in Seattle. And it's a collaboration with the Departments of Mechanical Engineering and Orthopaedics and Sport Medicine of the University of Washington. Please go ahead.
Yeah, thanks for the introduction. Please go to the next slide. Ankle OA is a disabling disease that affects walking capability. Footwear modifications and ankle foot orthosis are commonly prescribed clinically. The ability to reduce motion of the talocrural and subtalar joint has not yet been fully determined. High-foot kinematics are hard to calculate using external markers, especially in the subtalar joint and while wearing footwear. In this pilot study, we aim to investigate the effect of footwear and orthosis on talocrural and subtalar joint motion using a collaboratory model and biplane fluoroscopy imaging. We dissected a foot and implanted 10 stainless steel beads into the 3 hindfoot bones. We designed a loading device to reproduce a tibial progression angle during the stance phase, and then imaged by a biplane fluoroscopy imaging system. Please go next. Yep. And we tested 4 conditions, including barefoot, control shoe. Could you go to previous slide?
Yes.
Yeah, including barefoot, control shoe, rocker bottom shoe, and control shoe with an AFO. The motion of the beads were tracked up using our in-house software. Next. The bead-derived bone poses were used to calculate joint kinematics using the anatomical coordinate system. The resulting kinematic data were filtered and used for range of motion calculation. In the talocrural joint, next, rocker bottom shoe and control shoe with AFO conditions show a smaller range of motion in the sagittal plane. In the subtalar joint, next, Rock bottom shoe did not show a smaller range of motion in all directions. On the contrary, control shoe with AFO had the smallest range of motion in all directions. Next. Our results showed that rock bottom shoe and control shoe with AFO are able to stabilize the talocrural joint in the sagittal plane during the stance phase compared to barefoot condition and control shoe conditions. The rock bottom shoe did not show an effect on the subtalar joint. Next. AFO might provide additional stability in the transverse plane of the talocrural joint and additional stabilizing effect on the subtalar joint. This pilot study sets out a good foundation for our later markerless tracking validation. More trials will be collected for the AFO condition to strengthen the repeatability. Please note that Please note the results may not be generalizable to other footwear designs and orthoses. Thanks for your attention.
Thank you so much for presenting that, and thank you for all poster presenters for showing your research. I hope that it generates some discussions after this meeting. Thank you.
Great. So I believe that brings us to our last slide here, and I'll let Dan do the honors.
Oh, great.
You may.
Well, thank to our speakers, to Scott for having put together that fantastic presentation and put the effort in to record it ahead of time, and to his dog for mostly staying out of it. Thanks to Amy and Karen for fantastic presentations on a really important topic, and hopefully a future collaboration for many people in this group who are interested in getting involved and helping to come up with standards. I'd also like to thank our poster presenters. Those were fantastic mini talks. And then I also want to thank our poster reviewers who put in the effort to help us pull this together and review all of the abstracts at the ORS and come up with those ones that were presented today, which was a fantastic group. And finally, I want to thank my collaborators in the organizing committee, Bart Luberts, Bill Ledoux, and Mead Spratley for helping put this all together, without whom we wouldn't have this group. And I want to thank all of you guys for attending. This is our 4th year, and I think even though this wasn't in person, by far this is has been our best, most cohesive session, and I really look forward to the continued growth of this group. And I'm going to ask Matt to put the I think Matt did put the meeting spot in the chat. So if you want to click on that, that'll take us there. And we'll be sending around a survey for everybody as far as what you thought of this research interest group. And if you'd like to get involved in organizing, please let us know. Happy to have everybody who wants to participate involved. Thank you all, and that concludes our session. Hopefully we will see you in the chat room that Matt has put in the chat session.
Quick bump for anybody on the call. The foot and ankle podium session is Tuesday, 6 a.m. Pacific time. So set your alarm clocks.